Good morning, everybody. Welcome to this session about personalized medicine and rare disease. I'm delighted to share this session today. My name is Christine Dufès, and actually, unlike what's indicated in the program, I'm a doctor, not a professor yet, but thank you for the anticipated promotion, but right now, I'm still a reader, but thank you. So, I'm going to introduce our first speaker, Dr. Alejandro Paredes from Queen's University, Belfast, who is going to talk about the role of a nanocrystal technology in the management of neglected disease.
Okay, thank you very much, Christine, for the introduction. I am from Queen's University, Belfast. I am a lecturer there, and I did my studies, pharmacy and PhD in Argentina, and then I moved to Queen's. So that's relevant because I'm going to talk to you about a disease that is quite prevalent in Argentina. So during the last maybe 10 years, we've been working with nanocrystals, mainly to increase the absorption of poorly soluble drugs orally, but also we have explored other routes, as we will see in this presentation. And we have focused a bit on neglected diseases, and today I'm going to speak to you about the case of human echinococcosis. There was a way of putting lights here, I don't remember. But human echinococcosis is prevalent in Argentina, and treatments are still not very good for the disease. So to start, it was very important to me to show, I think it's working here now. Yeah, so first things first. Hope the chair doesn't take it too seriously. And also, yeah, and it was dedicated to Alex, who is chairing the other session. But not everything is football and wine and meat in Argentina. We are also an area of high prevalence for human echinococcosis. So this is a neglected tropical disease, according to WHO. And it's very tricky because it presents several challenges, not only therapeutic challenges, but also has a social impact because the disease happens naturally in livestock and dogs. So if you are a farmer and you have sheep in your farm that are infected with the parasite, you will have to sacrifice all the animals of the lot, and that will mean that you lose a lot of money. And then the treatment also is very challenging. So there is a burden for healthcare system because when in the human the parasite forms cysts that can be located in complicated places in the body that will need surgery and that will be very expensive. And as you can imagine, there is not always the possibility to have a surgery room or a hospital, especially in the impoverished areas where the disease is more prevalent. So there are several challenges related to this. So after surgery, the option is give antiparasitic drugs. But there are some challenges associated to that, as we will see in the next slides. So the cycle of the parasite is quite complicated. It happens naturally between dogs and sheep, but the human can enter the cycle accidentally, for example, by eating lettuce that they collected from the garden that were contaminated, for example, with dogs' feces. So it can be challenging. And once in the body, the parasite will form a very complex structure, which is a cyst that maybe is worthwhile remembering for the sake of this presentation, that has the protoxcolysis, which are the primary form of the parasite. This is how the cycle starts. And then a germinal layer from where the parasites are born. So that's the structure that is in the body of the human. So the parasite does this to protect themselves from the immune system of the human. So once the structure is formed, it's quite difficult to deal with. So medication can be challenging, and also surgery could be the first line treatment. So albendazole is one of the most commonly used drugs for this disease. Very, very hydrophobic, so it's effective against the parasite, but the problem is the poor absorption. It's a class 2. So the drug is administered orally in the form of tablets or suspensions. So it dissolves in the stomach, absorbs in the first part of the duodenum, and then is fully metabolized in the liver. So what you will find in the plasma is the albendazole sulfoxide, which is an active metabolite. Despite of that, we know that the parent drug, albendazole, is more active than the metabolite. But unfortunately, you will not see it in the plasma. It's fully metabolized. That's also an important point to take into account for next slides. So if we can work here, in the stomach and increase the absorption of the drug. That could be an advantage. And there is where we have been working with the nanocrystal technology. So poorly soluble drugs is a known problem for the pharmaceutical industry. Many new chemical entities and also approved drugs in high percentages are very poorly soluble. So we could use co-solvents, cyclodextrins, formation of emulsions, but this is not always possible. For example, to make a cyclodextrin complex, you need the molecule to fit in the cavity of the cyclodextrin, so not all the molecules will be fitting into that. If you want to prepare an emulsion, you will have to dissolve the drug in the oily phase. That's not always possible. So particle size reduction has become one of the easiest strategies to do this, primarily applying micronization of drugs, 2 to 10 micrometers maybe, and then since the early 2000s, new technologies allowed the development of smaller and smaller particles. So we obtained nanocrystals, which are nanoparticles made of the pure drug. So nanocrystals have, as I said, nanoparticles made only with drug. They have crystalline properties, particle sizes typically between 200 to maybe 800 nanometers. So they have an increased dissolution rate, Noyes-Whitney equation, an increased saturation concentration, so more drug is available for absorption. And then, because they are smaller, they have an enhanced bioadhesion, so they are more sticky to biological surfaces. So that increases the bioavailability of drugs, and there are more than 20 products approved in the market, most of them for oral administration, but recently intramuscular long-acting nanosuspension. So the technology has gained a bit of a momentum recently with the approval of Cabenuva and Apretude, two anti-HIV products based on this technology. So coming back to albendazole, we started this work maybe 2012, 13 approximately. We prepared nanocrystals initially with high pressure homogenization. We needed to apply 30 cycles of homogenization to obtain the nanocrystals. Particle size was around maybe 500 nanometers. And then we dried the suspensions by spray drying to obtain powders that you can see here in nanocrystals 4 were able to redisperse to the original particle size. So redispersion is critical because in the stomach you need the nanocrystals to be exposed to the solvent in order to have the increased absorption. So this is a little SEM picture where you can see the typical droplet shape of the spray dried powder with the nanocrystals indented there in the structure. So maybe this is a graphic way to show you what happens with albendazole when it goes to a stomach. So you can think of this beaker maybe as the stomach of a patient or of an animal. So in your left, you have the pure drug in water, and in the right, the spray-dried nanocrystals. So in the left, you see that the crystals form a raft, and they will stay there for very long periods, maybe for days, weeks, I don't know, we didn't try that, but I can ensure that the drug will not dissolve. It's very, very hydrophobic. Whereas the nanocrystals disperse well, so you will have the nanosuspension there ready for dissolution. So after this, and I'll jump the video because I think it's already made the point, we made pharmacokinetic experiments. So first of all, we did the dissolution studies. This is very basic for oral products where we saw an increased dissolution rate and also an enhanced saturation concentration of the drug there, and that corresponded to an enhanced oral absorption in mice. So following that, we went to Mar del Plata in Argentina, where Professor Celina Elizondo has a model of echinococcosis. So essentially, we infected the mice in the peritoneal cavity with the parasite. After 3 months, the cysts are developed, and then we start doing a treatment, applying albendazole orally as a suspension or as nanocrystals for a period of a month. After that, the animals are sacrificed, and we can obtain the cysts from the peritoneal cavity and do analysis of that. So what you can see here in the first graph is the viability of the protoscolysis. So this, if you want, baby parasites that are being created in the cysts. So the nanocrystals were able to reduce the viability significantly. 40% of them were still viable, so improvements are required, but the response was quite good. And in the pictures you can see the protoscolysis. This one here is a protoscolysis being born from the germinal layer. This is a normal protoscolysis. You can see there a crown of teeth and suction cups that the parasites will have to fix to the gastrointestinal wall of dogs. So these are very creepy creatures, and then what you can see there is a protoscolics affected by the albendazole control, and in this case, with the nanocrystals where all the morphology have been lost. Also, qualitatively, you can see the size of the cyst for the nanocrystals treatment was substantially low as well. So then we use microscopy imaging to see, a reduction in the amount of cells in the germinal layer, and also some damage inflicted here by the nanocrystals. We saw some vacuola and invaginations of the membrane, which indicated, again, damage to the germinal layer. So just to conclude this section, we were able to, affect the protoscolysis and also the germinal layer. So that means that we, managed to do some damage there to the growth of the parasites. Again, I think that more work is needed here, and we are now trying to optimize these and to get more drug into the cysts. So following that, we did pharmacokinetics in dogs in University of La República in Uruguay. So they have a big hospital animal there, and we assessed the absorption of the drug. It was, expectedly a bit higher than the control group. And then we were to a shelter where 200 dogs were living there, and all of them, well, not all of them, many of them were parasites naturally. So we took the feces of the dogs and we had to count parasites in many, many feces samples, so which not what really, really nice, but we were able to demonstrate that the parasite reduction was similar to the nanocrystals and the commercial formulation, but the dose applied with nanocrystals was substantially lower. So only with a quarter of the dose, we were able to kill all the parasites. By the end of the experiment, day 30, the animal tends to get infected again because the parasite is in the soil. So it's something challenging to manage, not only pharmacological therapy. You need to treat the soil also with other substances to kill the eggs of the parasites there. So the nanocrystals were well produced with high pressure homogenization. We wanted to do some media milling, which is probably the standard technique in the pharmaceutical industry. Maybe this picture is a bit of the science in Argentina. So a lot of, we want to do things, but sometimes money is not available. So we couldn't buy a mill. So we started to think about our own mill, and we designed this. We managed to get a patent out of this and to do a lot of work with nanocrystals, much smaller nanocrystals. And although it received a bit of bullying there, it was productive. We published maybe 10, 12 papers so far from this mill. We milled agrochemicals, drugs for multiple diseases. And we have done all the pharmacokinetic experiments. We have seen very uniform nanocrystals, now with sizes of 200 nanometers, maybe 210 nanometers there, very uniform, much precise control, because now we can regulate the temperature of the milling process. So quite promising. And then my colleagues in Argentina managed to take these nanocrystals, dry them, load them into a molten blend of excipients, and obtain these sprintlets that could be useful for personalized dosing of different molecules. So then when I was ready to do a postdoc, I moved to Queen's University Belfast to work with microneedles in the group of Professor Donnelly. This was in 2019, probably. So for those who are not familiar with the technology, microneedles are essentially little patches that contain a base plate and then microprojections that can be made of different materials, polymers, maybe metal, glass, and they can pierce the stratum corneum and deliver drugs in the viable layers of the skin. So you could think about this as an injectable with no pain or bleeding. So the needles are very short, so they don't touch the nerves or the blood vessels. So you can deliver drugs systemically and avoid the first liver pass, which is quite relevant for albendazole, as I mentioned before. So I thought, okay, we may load albendazole into these microneedles and see how it goes. So we prepared these systems. So microneedles were prepared using dissolving polymers. So whenever you apply them in the skin, the polymers will dissolve, and the nanocrystals will be exposed to the solution. So they will dissolve, probably slowly or not. You can play with the particle size. And then the drug will be absorbed by the microcirculation of the skin and distributed systemically. So we came up with this little ring concept. It was relatively recently published. It's a very simple technique to obtain bilayered microneedles. So you have the drug only in the tips of the microneedles, whereas the base plate is free of drug. So these are the microneedles. You can see how they have a pyramidal morphology there. So we prepare the nanocrystals first. We dry them using freeze drying, and then we load them into the microneedle tips. Something different here was the production of the nanocrystals. So we use now a very little version of an industrial mill, but reduced to the lab scale using these little glass vials, zirconia beads, magnets, and a stirrer to produce nanocrystals, also with very nice particle size and PDIs there. So the microneedles were applied to the skin of rats, and we did a pharmacokinetic experiment there. So as you can see for the oral treatment, which is, in this case, the control, we saw the albendazole sulfoxide in red as the main drug detected in plasma. So this was what we expected. And when we did the nanocrystals, the absorption was a bit higher, but the patterns were as we expected. Sulfoxide first, and then the sulfone, which is not active, much lower. And we also managed to see a bit of the parent drug here. So when we did the microneedles, we saw an inverted trend in the pharmacokinetic profiles, because now we were able to see the albendazole parent drug, and then the sulfoxide and the sulfone were much lower, as you can see here. So obviously, with the nanocrystals, the absorption was a bit higher, because there you have the particle size effect that will enable more drug to be dissolved and then able to diffuse through the microcirculation of the skin and then be absorbed for distribution. Critically, you can see here the potential for long-acting that this has. So in this case, albendazole maybe is not the biggest relevant drug for long-acting, but we have explored the combination of nanocrystals and microneedles quite extensively, and we have applied that to malaria, HIV, and also for the treatment of chronic diseases, maybe hyperlipemia, and other medications that need frequent dosing. So that's an important point here, and just wanted to highlight that we could and we have translated this strategy to other conditions as well. Finally, I wanted to comment on a recent platform that we have developed in my lab. So it was a bit of an exploratory work that we carried out with colleagues from Polymat, Marcelo Calderon there. So they have a lot of experience in the development of new materials, polymeric gels and nanogels. So it was a bit of an exploratory work, and we enjoyed it a lot. So we obtained these eutectogels here that are very elastic, and they are made with no water at all. So you form an eutectic solvent, you add gelatin there, and now you have these very nice materials that have a lot of elasticity, and they can deliver drug locally. And we loaded nanocrystals of curcumin as a mother drug. Curcumin is always antioxidant, antibacterial, antitumoral. So it was just a model drug, and it's very, very hydrophobic, terribly hydrophobic. So we made the case, just to show the concept, and we published this recently in the Materials Today bio. So we obtained the nanocrystals following similar protocols. So we went from 37 micrometers to 164 nanometers. Again, the PDI was 0.2, relatively okay, monodispersed nanocrystals. And then we loaded them into the eutectogels. We did a lot of mechanical characterization here, but you can see in the picture how they, how elastic they are, how nicely they extend without breaking. This little video here maybe helps to show in the real life how they are. So we did mucoadhesion here, and we demonstrated that they are quite good to stick to different surfaces here. And the video demonstrates how you can manipulate those in the lab. You can play with the thickness, with the shape. I mean, it's probably an interesting platform, for applications that we are now trying to open. And of course, if you think of something, just let's have a chat. So you can heat and recast these gels, and we did that using the Queen's University Belfast acronym, And then we saw that the particle size and the PDI was maintained after we hit and recast 3 times here. So that's something maybe applicable to other areas where drug delivery is not critical. So something for you maybe to pay attention. And then together with Eneko Larrañeta, one of my colleagues in Queen's University Belfast, we made little meshes that we prepared by 3D printing. So if you apply some heat, these gels will become semi-liquid, semi-solid, so you can play a bit with the printing, and then we were able to show that after printing, the physicochemical properties of the gel were relatively okay, no changes there, and the particle size, again, changed a bit, but not much. Then we did some mucosal drug delivery. So first of all, we did the in vitro drug release. We followed it for 28 days. We saw some potential for long-acting drug delivery there using the detector gels and the nanocrystals. And then we measured the drug deposited on the surface of the mucosa using HPLC and also some fluorescent microscopy here. You can see the nanocrystals were able to deliver more drugs in comparison to the same gel loaded now with a physical mixture. So again, I think this may be something interesting to explore. I've been speaking to people here in the conference that are doing sensors. So these gels have very nice potentials to do sensing. So you can apply them in the skin, maybe do some electrical circulation there if you want to measure something. So maybe interesting to have a chat about and maybe explore ideas for collaboration. So final remarks for this presentation. Nanocrystals have been long now used for enhancing drug absorption of poorly soluble drugs. We apply them to the case of albendazole. It worked well. There is a pharmaceutical company that works with veterinary products. They are adopting the technology and they want to develop an antiparasitic drug or product for dogs. Then we combine the nanocrystals with dissolving microneedles. Very promising results there. As I said, other applications have opened there. Many other diseases, we have a strong focus on HIV in the group at Queen's University Belfast. And then we explore the detector gels to deliver drugs locally to the mucosal tissues. So other areas of research we are exploring is leishmaniasis, relevant for this presentation. I didn't have time to show a lot of that, and it's also quite incipient. I have a PhD student doing work in this disease, and another student doing lymphatic filariasis, another disease that's quite tricky to treat. The parasite is enclosed in the lymphatic system. The drug doesn't reach very easily there. So we can maybe play with the nanocrystals and send the drug to these tissues. So I wanted to finish the presentation with a question. So maybe you help me with this. So I am thinking of these nanocrystals as maybe highly loaded Trojan horses. So when we compare nanocrystals with a lipid nanoparticle, the drug loading will be much higher. Lipid nanoparticle or polymer nanoparticle. I don't want to make enemies. So if you think of a polymer nanoparticle, okay, 5%, 20% drug mass loaded into the nanoparticle, okay? But these nanocrystals are made entirely of pure drug. Okay, so again, very preliminary work. Marta Garcia-Fuster from University of Murcia has been in my lab, and we developed these nanocrystals. We decorated the surface of nanocrystals with different ligands. She took them to Spain and put it in contact with cancer cells. And what we saw here is these little stars. Which drug is this? Curcumin. So curcumin, again, is a model drug. So we were able to track the particles and see them probably inside the cells. We are now trying to see if they are inside, maybe in the surface. We are not sure. But I think it's something interesting, and although the drug will dissolve at the end, it will dissolve where we want. That's the hypothesis of work. So hopefully this will bring me again to this conference, and I will be able to show you more about this and see if the idea worked or not. So this is my former group in Argentina. Dr. Santiago Palma there was my supervisor on a PhD and a bit of the postdoc. And then this is my group at Queen's University Belfast. I think the configuration is as is now. We have some summer students visiting at the moment. So thank you very much to everyone, and I'm open for questions.
Thank you very much for the very interesting talk. Do you have any questions?
Just to warm up. Wonderful talk. I mean, it's just amazing the work that you presented. I have to say that I'm quite ignorant about this kind of nanoparticles. And I was wondering about how you can control the dissolution rate, because in fact, I understand that using polymers and other materials, we can certainly control the release rate, but in this case, it's going to be highly determined by the solubility and the dissolution rate. And the other question I have is regarding the solvents. How important the solvent is in the processing of these particles.
Yeah. Sounds good. Yeah, regarding the first question, the intrinsic properties of the drugs are critical. Yeah. So we have been playing with different coatings of polymers that you can cross-link. So you form like a little net around the crystals. So if that net is sufficiently cross-linked, for example, you will be able to control the release of the drug. Now, if you have a nanosuspension, there will be an amount of drug that is dissolved, an amount of drug that is solid. And that's one of the main questions that we are addressing now. How much of the drug is dissolved? How much of the drug is in a solid state? When? Because it's not the same 1 hour than 3 hours, or maybe 24 hours. So many of our work now is trying to understand more about the crystals as particles. So drug delivery maybe is something explored, and you can expect more absorption if they are smaller. But my group is trying to focus on these nanoparticles as entire vectors. So your question is very important. And the other one about solvents, where this production technique doesn't require organic solvents. So we use water, a surfactant, maybe a polymer, and then we break the nanocrystals, and once they are breaking, new surfaces are being coated by these polymers. So the stabilization of the system will depend a lot, on the kinetics of that breakage of the particles, or maybe the amount of drug you have in the system, the amount of beats that there is in the mill. So we have done a lot of work there, but I think that we still, much more to explore and understand.
So you don't want to use solvents?
No. You can form them by precipitation,
yeah.
But then you can't ensure that there is no tiny amounts of the solvent inside the crystals. So if we can, avoid that and get nanocrystals of 100 nanometers using these mills, there we go. We don't use the solvents. Thank you.
Thank you, Alejandro, for this amazing talk. I was wondering if you have thought about the possibility of using this curcumin gel for the treatment of, for application in wound healing, especially chronic infected wound.
Mm-hmm. This is interesting, and I have bad news about that. And I've heard the news just before coming here. So we did some meshes, and we said, okay, now we have them loaded with curcumin. Let's just find an application for this. Go to the microbiology guys, spoke with them, put the meshes in contact with the bacteria, and there is no killing. There is no killing. So bacteria are happy swimming in curcumin. So probably this particular type of bacteria is quite resistant. So I understand your point, and the eutectic gels are highly compatible. It's gelatin, and the other solvents are very small molecules, glycerin, no problem with that. But yeah, I think we may also think a need of cross-linking, because these eutectic gels will eventually dissolve. So if you want to provide a scaffold, you will need to cross-link them so they remain as a net. But it's interesting. I think it's something we definitely need to explore. Antioxidation, antibacterial, in theory, capacity would be very useful for wound repair and tissue regeneration. And we have been speaking about this with Giuseppina Sandi, who is in the audience, about doing some systems, try to explore this. Thank you. Yeah, you're welcome.
Thank you for the very nice talk, Alex. So I have a question about the mechanical strength of the microneedles. So can you comment on that? So did you do any tests on the mechanical strength of the microneedles? So especially when you load the nanocrystal, mm-hmm. So how that changed the mechanical strength of the microneedles? The second question I have is about the composition of the microneedles. So you mentioned about the dissolving microneedles. So I get you used like biodegradable polymers for the microneedles. So how that interact with the nanocrystals?
That's a good question, and
Thank
it's
you.
part of the essential packages of characterization of microneedles. So I didn't have time to present all that, but what we do is just, there is a paraffin test, so we can put the microneedles, insert them in layers of paraffin, and then count how many holes you have in each of the layers of the paraffin. This is a technique reported by some guys at Queen's University. So that's one of the tests. And the other one is you take the microneedles and you press them against a flat surface. And then you measure the height of the needles before and after compression, and then you can make an index, of mechanical resistance there. And about the materials, the most typical are PVP and PVA. So if you use polymers of less than 60 kilodalton, they will absorb and, in theory, be eliminated in the kidney without making any mess there. So these are the two typical polymers. Microneedles have been prepared with hyaluronic acid, Pullulan, HPMC, PLGA. So all those polymers are useful, but in this case was PVP, PVA, and then we loaded increasing concentration of the nanocrystals, and then we measure mechanical properties. So the objective was to load as much as possible of the nanocrystals while keeping the mechanical properties. That's the approach. Yeah.
Thank you so much for your talk, some amazing science. I was just wondering whether anything is being done about environmental treatment, or whether it's possible for the nanocrystals to be used for complete eradication, because as you mentioned, treatment is not a complete solution. Yeah,
so this disease is part of these paths that the WHO has set to eliminate these diseases from the world. And many of the steps are, medication is just one single step, and accessible medications. You cannot have albendazole, because it depends on the fatty content of the food. So imagine in some areas in the world where the diet is grains and there is nothing of fat. So you cannot rely 100% on medication. So medication has to be effective, accessible, absorb well. So yes, there are treatments for the soil, but these parasites are very, very smart. Very smart. So some of them will be in the soil, waiting for maybe the dog to touch them, and they will go in the dog via the skin. So they are very, very smart. So it's a difficult problem. We have done nanocrystals for agrochemicals, right? For fungal diseases of plants. And some drugs may be applicable here to maybe spray the soils and try to kill the parasites there. But that's a good question. That's a good question.
Any final question? Not for the moment, so you can still rediscuss this topic about treatment of Echinococcus parasites during lunchtime. So thank you very much again.
Thank you. Thank you.
Okay, so our next speaker will be Dr. Ioanna Mela from University of Cambridge Royal Society University, who is going to talk about the DNA nanostructures for targeted antimicrobial delivery.
Thank you. Thank you very much, Christine. And thank you to the organizers for putting together a fantastic conference and for giving me the opportunity to be here today. So yeah, DNA nanostructures for antimicrobial delivery. I guess the first question is, why do we care? Why do we care about antimicrobial delivery? And why do we care about DNA nanostructures? And of course, the first part of the question is a lot easier to answer, in the sense that I'm sure that everyone in this audience appreciates that antibiotic resistance is a major healthcare issue. It is projected to have major socioeconomic implications, and to put that in numbers a little bit, by 2050, the projection is that we're going to have about 10 million deaths that will be attributed to antimicrobial resistant infections, and that is more than cancer and diabetes combined, for example, with an associated cost of about 66 trillion pounds, and this number seemed completely wild to me a few years ago, but having seen the effects of the COVID-19 crisis, it is unfortunately a little bit easier to digest. What is perhaps less known is that we already have about 25,000 people dying each year only in Europe as a result of 5 key resistant antimicrobial resistant infections. Now, of course, it's not all doom and gloom, in the sense that there is a lot of interesting research going on around antimicrobial resistance, and this can be broadly divided into 3 main categories. One has to do with antibiotic discovery in itself. The other has to do with the accurate and precise biochemical and biophysical characterization of our bacterial targets, so that we can understand them better, we can perhaps understand their vulnerabilities better, and therefore we can target them better. And the last one has to do with drug delivery, and perhaps finding clever ways in which we can target bacteria and therefore potentiate our existing drugs and give them a new lease of life. The research in my lab focuses mostly in the last two categories, but today I'll talk to you about a little project that we think was quite neat and has to do with drug delivery. So what we do is we use DNA nanotechnology. Now, we already heard about some really cool DNA nanotechnology-related work yesterday, but just to recap quickly for any of you that might not be familiar with the concept, the usual way in which we make a DNA nanostructure is by taking a long, single-stranded circular piece of DNA, mixing this with hundreds of short oligos that we'll call staples, and by putting this mixture through a thermal cycler, we will bring the staple oligos will bind the scaffold on pre-designed shapes, and they will bring and hold this nanostructure in shape. When the concept was first introduced in 2006 by Paul Rothman, we could only design 2D nanostructures, but the field has advanced so that we can make 3D nanostructures, nanostructures that consist of smaller nanostructures, nanostructures that can change conformation depending on the environment they find themselves in, and so on. Of course, this is not just fancy nano-Lego, but one of the main advantages of these systems is that each one of these, say, on average, 200 oligos that hold the nanostructure together can be functionalized to carry molecules of interest, whether these are proteins, enzymes, fluorophores, drugs, and so on, give us a nanostructure that has lots of flexibility, can be modified very easily, and can act as a little bit of a molecular Swiss knife, if you like. So what we did in the context of this project was to design a little 2D nanostructure that looks a little bit like the 5-face of a dice, or a shreddy, or a potato wedge, depending which one of my collaborators you are. But this is the shape. So a rectangle that has 5 holes in, 5 wells. And we designed this nanostructure to have 3 different functionalities. The first one was the addition of an antimicrobial enzyme, so lysozyme in this case, that we attach to the nanostructure through a biotin-streptavidin bridge. So we have can you see this pointer? We have 2 biotinylated staples pointing into each well, and there we will be attaching our antimicrobial enzyme. The second one was the addition of aptamers on the perimeter of these nanostructures. So aptamers are short oligonucleotides that will assume a secondary structure and will bind specifically to targets. These ones are broad-range aptamers that will bind whole bacterial cells, so we don't know exactly where on the bacterium they bind, but we know they bind the bacterium. And the last one was just the addition of 4 Alexa 647 molecules that would act as a detection beacon for this nanostructure down the line. So that was all very good. We're very happy with our design. But of course, we need to know whether these functionalizations actually work. And that's what we set out to do. The first thing we wanted to know was, does this form as designed, and can we load it with antimicrobial enzymes? So for that, we performed a series of atomic force microscopy experiments. And you can see here in 2D and 3D, the DNA nanostructure bare, so just formed from the scaffold and oligos. The first loading step, so streptavidin addition, that starts appearing like blobs on the sides of the wells. And here at the bottom, you have the fully loaded nanostructure. And by doing some volume analysis on the blobs, we were able to estimate that we have approximately 2 lysozyme molecules per streptavidin per well. So the first functionality seems to be there. We seem to be able to load this guy with our antimicrobial enzyme. But does it associate with bacteria? Is there any association with our actual targets? To understand that, we moved on to structured illumination microscopy. And we had bacteria expressing GFP, so we used a gram-negative and a gram-positive model, so an E. coli and a Bacillus subtilis model. We incubated with our Alexa-loaded DNA nanostructures. And we can see that we have a good association of DNA nanostructures with our bacterial targets. And if we quantify these images a little bit more, we were able to see that we have approximately 20% of the bacterial surface covered by nanostructures. Excellent. But is there any point? As in, do we get any benefit from delivering lysozyme in a targeted, concentrated manner on the bacterial surface rather than adding it to the culture solution as you would do? To understand that, we just did some bacterial growth curves, and then we saw some interesting things. So there are a few things going on here. If I could draw your attention to the orange and green curves. So the orange curve is bacteria growing in the presence of lysozyme in their culture medium. And the green one is bacteria growing in the presence of DNA nanostructures loaded with the same concentration of lysozyme. And we're able to see a significant reduction both in the growth rate and in the total biomass that we had in these bacterial cultures when we deliver our antimicrobial in a targeted manner. And that was good news for us, at least as a first step. So we can potentiate our antimicrobial enzyme when we deliver it in a targeted way. Now, we saw some other things that were less explicable, if you like. And that is that in the case of the gram-negative, the bacteria are not entirely happy when we incubate them with plain DNA origami, plain DNA nanostructures. And by plain, I mean DNA nanostructures that are still functionalized with aptamers, so they can bind the bacterium, but they are not carrying any antimicrobial. And if we quantify the growth rate of these guys by fitting a modified Gompertz growth, we understand a little bit, we see a bit more clearly what is going on with the growth rates there, which is that we have the reduction only in the presence of origami or nanostructures carrying lysozyme in the case of the gram-positive. But we also have a reduction in the growth rate in the presence of just aptamer functionalized origami in the case of the gram-negative. And this has actually created a whole new research direction in the lab, which is to look for aptamers that will not be used as the anchoring apparatus solely anymore, but we are looking for aptamers that will act as pharmacologically relevant molecules in themselves in an antimicrobial context. But in the interest of time, I'm going to leave this here. I'm going to thank everyone who has supported this study, funders and people, not that funders are not people, you for your attention, and I'm happy to take any questions.
Thank you very much for the fantastic talk. Do you have any questions?
Thank you. Great talk. How stable are they over time in the culture medium, and how can you find out?
We don't have direct evidence. We are just using fluorescence from them, but which of course, doesn't prove anything. About 12 hours in growth medium, in the presence of bacteria. In their solution in the fridge, they are stable for at least a couple of months. We got bored AFM in them after that, but yeah.
Excellent talk. So how long do they stick on to the bacteria? Because obviously they stuck there quite long. Second one onto that, what about TB? Because obviously that's slightly different. It's not.
Say again?
So first one is how long do they adhere? Mm-hmm. Do they leave? And the second part is like TB has got an even slightly different. It's not really gram-positive or negative. It's its own one. So do you know if it sticks to that?
The first question, I mean, the short answer is I don't know how long they will stay on intact. We can only indirectly kind of try to think about that in terms of the antimicrobial effects that we see. They will eventually start getting eaten up by DNases. They will eventually start degrading because of the local pH and ion concentrations and so on. which can be a good and a bad thing in the sense that it depends what you're loading. If you want what you've loaded to fall out, it could be a good thing. If you don't want that, it can be a bad thing, but I cannot give you a number in hours. Sticking nanostructures to other target organisms is only dependent on our aptamer selection. So the better our aptamer selection becomes, the bigger the variety of targets we're going to have. So possibly, but we need an aptamer. Or another sticky molecule, like a nanobody, for example. That could also work nicely.
Hi, I've got a couple of short questions. So your grid structures, can you make them larger so that you can load them with more lysozyme if necessary? And also, the other question is, do you actually know what your mechanism is for the kill that you're seeing with the gram-negative and just the plain aptamer at all?
To the first one, yes, we have flexibility in terms of size. Another way to load more antimicrobial would be to find a slightly more elegant way to stick it on rather than streptavidin biotin that is efficient but cumbersome. So yes. And the second was, sorry.
What was it? Do you know?
Oh yeah. We haven't answered this yet. We have two things that we are testing. One is just because DNA is negative, right? And it will interfere with membranes, so it could be just causing some local disruption on the membrane that then has downstream effects. The other, which I'd like to prove, but we don't have any data in our hands that is very solid yet, but we are working on it, is that the aptamers are binding something that is important to the bacterium. And that's why we are taking this direction now to try and see if we have aptamers that we have pre-selected to bind a specific bacterial membrane protein, say, can we then put the bacterium in enough of a disadvantage to cause it to not die necessarily, but be in a metabolic disadvantage. Yeah.
Maybe one?
Yes.
Well, one more question. Of course, great insight, etc. Great future on these technologies. My question is, having seen all this lovely molecular Lego and building, it reminded me that we have myriads of targets that could be aptamers for, and myriads of structures of molecules that could be loaded for within this origami structure. Any plans to make everything computational?
Yes. So this is the bane of our lives at the minute, in the sense that, in my opinion at least, what will revolutionize aptamer selection is trying to have a more rational computational approach to it. Because right now we're just screening. We have a random DNA library. We screen. If we get hits, happy days. If not, having a way to predict, or at least being able to tune in a more rational way our sequence/structure for the aptamer versus a specific protein is something that we are working on at the minute. But the training library is practically non-existent because there is a wealth of structure for proteins, some for DNA, very, very little of co-crystallized proteins with DNA. But absolutely, this is the dream.
And others way around, for the cavity to accommodate molecules of interest, inside.
Yeah, absolutely.
Any final questions? No? Okay, thank you very much. Okay, our next speaker will be Miss Mareike Werle from Queen's Mary University, London, who is going to talk about polymer nanoparticles as a targeted drug delivery system for the diagnostic and treatment of rheumatoid arthritis.
Okay, oh, sorry. Is this working? Yes, perfect. Okay, great. Thank you very much. It's really an honor to be here and to be speaking in a conference like that. I'm a PhD student from Queen Mary University, London. I'm in an immunology lab. and I'm talking today about polymer nanoparticles as a targeted drug delivery system for the treatment of rheumatoid arthritis. I'm the only one in the lab who's waving the flag for nanomedicine and nanotechnology, so I hope I can present that in a good manner. But as I said, because I'm a PhD student, probably my presentation will be a bit less advanced than the ones we've seen already. So I start by giving a little bit background to rheumatoid arthritis. Rheumatoid arthritis is a chronic systemic symmetric autoimmune disease that affects around 1% of the adults. The patients suffer from chronic pain, swelling, stiffness, loss of function, and deformity of the joints, as you also can see in this picture here. Rheumatoid arthritis is characterized by a persistent synovitis, chronic inflammation, systemic chronic inflammation, and often autoantibodies that leads to joint damage, cardiac destruction, and bone remodeling. As I said, this is an autoimmune disease, so also young people can get it, and it's therefore in comparison to osteoarthritis, for example, which isn't. And the purpose of my PhD thesis here is, even though we had big breakthroughs in this field with biological agents and DMARDs, which are disease-modifying anti-rheumatic drugs, like methotrexate, which is for sure for some of you a word, because it's also used for cancer therapy, but it's also in a different dose used for rheumatoid arthritis. But still, though, around 40% of the patients do not respond to any treatment yet. And if they do, the two biggest problems we have are basically severe side effects and low efficiency at the site of inflammation. So, for example, to give you an overview, methotrexate has pulmonary fibrosis, hepatic fibrosis, renal insufficiency as a side effect. Tofacitinib, as you can see here, is infection, diarrhea, and liver toxicity. So there are things that we, of course, try to minimize and try to avoid. Therefore, synovial-targeted nanotherapies could improve the efficiency at the site of inflammation directly and minimize the systemic side effects everywhere else. And this is a slide that you all know, so I'm going very shortly over that. You can choose between the materials. In my case, I concentrated on the polymer PLGA. We can do different surface modifications. In my case, I coupled an antibody that I will speak about very soon. And you can choose between non-targeted or targeted drug delivery. In my case, like I said, I'm choosing targeted drug delivery. So we found, and I was a little bit involved in the development and testing of this single-chain of VFC antibody that was produced in our lab as well. So it's a monoclonal antibody, and it is specific for the inflamed human synovial tissue that is in the joints. And as you can see in the immunohistochemistry here, in picture A, there is a staining from immunohistochemistry with the F7, and for liver, lung, pancreas, and spleen, there was nothing found. I also confirmed that by doing an immunofluorescence. So the F7 here is shown in yellow, and you can see it stains the vessels for human synovial tissue. I went on to modify my nanoparticles. So on the left side, you can see a schematic setup of the F7. And then with PLGA, I peculated that. I put a maleimide on top for the coupling, but I will come back to this, and encapsulated the drug, or FITC in that case, in the beginning, also to be able to follow the particles around. We optimized the nanoparticle parameters. It sounds a bit funny to present that in a conference like that, because you've all done that. So in the beginning, as I was the first one to ever produce nanoparticles in my lab, I had to set up everything really from the beginning on. So we tried different encapsulations in the shell, in the core, drug amount, polymer molecular weight, oil-to-water phase ratio, and steering speed. These are just very few of everything that I got out. As you might know, these tables are huge and cost a lot of time. So in our case, we have around 170 nanometers as a diameter. We have a polydispersity index, which I'm quite proud of 0.07, 0.08. Drug release around 5 days, but I will also come back to this. And an encapsulation efficiency for FITC around 80 to 100%, and for methotrexate 43 to 62%. Even in the coupled diameter, we stay below 250 nanometer, which was our goal, because above that, complement system would get involved, and this is something I'm trying to avoid. PDI is still below 0.3, and the coupling efficiency between the F7 antibody and the nanoparticle is between 60 to 80%. I went on for characterization with these particles. Also, I have to say, all techniques I'm showing here, I did myself. So the electron microscopy, as well as afterwards protein corona analysis with mass spec. And I compared SEM analysis, and as you can see with freeze drying my nanoparticles, actually you have water artifacts, which weren't that nice. So I went on to try different techniques like critical point drying, speed vac, and lyophilization, but still in the end we went with transmission electron microscopy in the liquid phase, with an uranyl acetate staining that you can see on the right, and that confirms the size as well. Also, I double-checked the size always with DLS like we all do, but also with a nanosite that I will show a picture afterwards. In the beginning, I checked, or I kind of tried to compare the drug release between the drugs. I put my nanoparticles in a semi-permeable membrane and measured the drug or Physi concentration in the PBS afterwards. Due to osmosis and diffusion, the particles released them. This is just a little bit of a setup because those were two curves that actually looked too good that I didn't want to ignore them. So the behavior of the Physi and the methotrexate was quite similar. In those 2 days, I optimized the whole process afterwards to 5 days, and the methotrexate was done within ELISA. So the antibody coupling that I did was done via a thiol-Michael addition reaction, which is done as I included, you can't see this now here a bit, but there's a free cysteine linker on the FC region of the antibody that I modified, and I coupled this via this Michael addition reaction to the mulamides that I included in the polymer, and this forms a covalent thioether bond between those two, and therefore also the orientation of the antibody is given. I checked the coupling behavior with the protocol that you see here that includes the BCA and a Comassi staining. And you can see because of the concurrence between the antibodies and the binding sites, you have this maxima-minima principle. And I checked the coupling speed. And as you can see here, we have around 80% coupling efficiency overnight. I went on to test the cell viability with a cell viability assay of the particles without anything. The pure empty nanoparticles are toxic. In this case, I took HEC293 T cells as they are easy to cultivate, and also they are epithelial-like cells, so I wanted to try with those. I also included different cell lines, but I'm not showing them here due to the time. And in this case, as you can see, thank God, the empty particles weren't toxic. And I went on to test the whole process with the F7 coupled as well. This also didn't show toxicity. I included here the methotrexate-loaded nanoparticles, which at the moment doesn't show an effect yet. But at the moment, I'm also trying to see the therapeutic effects and the dose that I need. So this is something I'm working on at the moment. I went on to test protein corona with silver staining and Comassi staining and incubated them in healthy donor human blood serum and plasma. I did 2 different experiments to see what's going on, basically. One was to test different kinds of nanoparticles that I have, the Physi one compared with the methotrexate-loaded one and compared with the empty one, and also the F7 conjugates and without the antibody. And another one to test the binding strength, basically by testing different incubation times and different wash cycles. This is what we found out, and this is just a very, very little part of that, and as I said, this is very preliminary data. I found, I think, around 140 proteins per gel that I ran, so I'm trying to get through all this data at the moment. There are some that we were expected, like albumin, fibronectin, haptoglobulin, and apolipoprotein E, for example, but also complement system. As it is healthy donor human blood serum, we were expecting to have a binding from complement system, but at the moment I'm trying to see if there's complement activation going on or not, which is a difficult thing might everybody know who is in protein corona as well. And as a summary, I can say I encapsulated the methotrexate, Physi. I also tried different drugs, but I didn't include this here in this process. I have a drug release from around 5 days, a coupling efficiency 60 to 80%. We kept the mean diameter below 250 and the PDI below 0.3. And as you can see, my nanoparticles are spherical shaped. I also tested the storage test, and this was just for the empty nanoparticles, but with the DLS and the PDI, the mean diameter and the PDI stays stable for a year at 4 degrees. The other ones are still in test. And thank you very much. I want to thank my institute and my cooperators, and thank you for your attention.
Thank you very much for the great talk. Do you have any questions?
It was an excellent talk. And I had to step out for a minute, I apologise, but I came back in just at the right time because you said compliment, and I think that pulled me back into the room. Can I ask how you're checking your complement activation at the moment?
Yeah, so this is a huge problem, and I would actually love to get input on that. So at the moment, what I'm doing basically is doing a liquid chromatography mass spectrometry, and I'm checking with Mascot and Spectromil the proteins, but what you can't see and what I'm trying to see is basically, you can see we have C3 inside, but we can't see if it's cleaved or not. Because what I can check is I get short sequences out, so I can see, okay, this is 3A or this is 3B, but what I can't see if it's cleaved and alone or if it's still in the complex C3. So this is something I'm at the moment really struggling with, and I'm trying to look downstream of the cascade and also trying to look into different pathways if I see some activation here. But this is, I just got the results out and still going through the 140 and trying to figure out what I'm doing with this.
Because I think there's something important to bear in mind is that just because you're seeing difference in split products associated with the particles doesn't necessarily mean that you'll get full activation of the cascade. We should get in contact because it's something we do quite a lot of. I know that if there's anyone from my group in the room at the moment, they'll be tensing up thinking that they're going to get more materials to look at, but, but we can certainly help you with some suggestions.
I'm absolutely happy with this, of course. Yes, absolutely. It would be amazing.
That's great.
Yeah, great. Thank you so much.
Thank you. Do you have any other questions?
Thank you very much for the interesting presentation. It was just a quick curiosity. I was just wondering if you already know what are the future perspective of your work, where you're going or what you will do next.
Yeah. So thank you for that question as well. Yeah, at the moment I'm planning quite a lot actually. So I'm trying also to look in the immunoresponses by an ELISA to see, for example, TNF alpha and interleukin 6, for example. These are just things like that. Then I'm trying to see the cell uptake, how we should exactly do it, where the antibody will bind exactly, and how this goes on if we go then in vivo. So I'm also planning to use an AIA model. This is the adjuvant introduced arthritis model that is quite often used for this. So there's still a lot to go, actually. And the protein corona is a big part, so I don't want to underestimate the work that's getting into that. So let's see, but these things are very interesting, and I'm also quite interested in, for example, cRNA, but this is a completely different thing, so let's see how far we can get.
Any other questions? Not for the moment? Okay, thank you very much.
Thank you.
Okay, our next speaker will be Dr. Manuel Bañobre-López from the International Iberian Nanotechnology Laboratory, and is going to talk about targetless solid tumor targeting through smart magnetic nanocomposites.
So thank you very much. So in this talk, I'm going to try to introduce you a different way of targeting solid tumors by using a combination of responsive magnetic nanocomposites and magnetic stimulation. So specificity is one of the biggest challenges of medicine, both from the biological and also from the translational point of view. So there are many examples of targeting strategies that work very well in vitro, but when they move to in vivo, they fail. And even worse if they reach clinical trials at some point. So despite these limitations, there has been a significant progress in the development of targeted medicines. For example, in the scenario in oncology, in the scenario of breast cancer. So we can find several examples of targeted medicines, but all of them are based on the specific recognition of a receptor which is overexpressed in the cell membrane of the tumor cells. So basically, they are drug conjugates attached to an antibody that provides this kind of specificity to the drug molecules. But there is in this same scenario, in breast cancer, there is a breast cancer subtype, which is the triple negative breast cancer, which is the most aggressive, actually, and the one with the worst prognosis. It is characterized by the no overexpression of any hormonal or epidermal receptor. So, and that's why there are no targeted treatments available for this breast cancer subtype. So the question that we made ourselves was, how can we target something which is untargetable because it doesn't overexpress any receptor that we can target? So we came up with this approach. So basically, we use as a model this classical carrier system that we customize in order to provide a combinatorial thermochemotherapy treatment in which we place our targeting motif. So it is basically composed of a solid wax matrix, a solid natural wax matrix, which is sterilized in water solution by a surfactant, and in which we can co-encapsulate magnetic nanoparticles and also drugs. In our case, we use the chemotherapeutic drug doxorubicin and iron oxide nanoparticles. We can place also some dye in order to do the in vitro tracking of the formulation. And using this system as a model, we place our targeting motif that I will describe in a minute. So we follow a safe-by-design approach. Most of these components are actually FDA approved, and many of them are used already in humans in different, as a component in different medicines and formulations. So magnetic nanocomposites are very interesting in the biomedical field because we can take advantage of the encapsulating properties of the organic matrix and the physicochemical properties of the iron organic counterpart. So in the case of magnetic nanocomposites, the magnetic component enables different medical technologies. For example, non-invasive MRI, so they can act as T2 contrast agents in MRI. They show very high transversal relaxivity values, but also they can act as magnetic effectors in magnetic hyperthermia. So we saw yesterday some talk about this. So we can apply an oscillating magnetic field, so these magnetic nanoparticles will heat up, and this temperature increase can not only be used as directly as a thermal ablation therapy that kills directly the tumor cells, or as an adjuvant of in other combinatorial treatments in combination with chemotherapy or radiotherapy, but also it can modify the drug delivery profile. So we can, externally and on demand, we can modify the drug delivery profile, so we can enhance the drug release at some point. So with this in mind, we place our targeting, or we develop a targeting strategy that we can couple to this system. So it is based on the combination of two different ligands. One of them is a cell-penetrating peptide, which promotes cell internalization, and the other one is a pegylated ligand, which has a temperature-sensitive bond. So it protects the cell-penetrating peptide, it seals this, and provides at the same time the system with stealth properties. So the final idea is that we can administer systemically, intravenously, this system. We can apply magnetic hyperthermia in the tumor area, so we can induce the heating of these particles. This temperature increase will clip this pegylated ligand and expose the cell-penetrating peptide. And this will promote the accumulation of the formulation in the tumor region. So let's go to some results. So these are physicochemical results from the material point of view. So basically, we have the crystalline structure of the solid wax in the core, the magnetic properties, which are iron dependent, the capability of the system to increase the temperature when we apply magnetic hyperthermia, an oscillating field, and the ability to reduce the T2 relaxation time with increasing iron concentration. So let's go to in vitro now. So the first thing that we wanted to do was to validate this targeting strategy. So for this, we studied the cell uptake of our thermoresponsive formulation and compare it to two different controls. One, which is the same formulation, which is non-functionalized, and a second control, and this is our negative control, and a second control, which is the formulation functionalized only with the cell-penetrating peptide, which is our positive control. And what you can see here is that when magnetic hyperthermia is not applied, our thermoresponsive formulation is not able to enter the cells. But when we apply 1 hour magnetic hyperthermia, our magnetic formulation, which is in red because of the fluorescent that we place on it, now you can see how they are able to penetrate the cell membrane of these cells. And this is what you can see here in this quantification of the fluorescence intensity in these confocal images. So from the therapy side, we can see, a long story short, we can see that those sample and control formulations which have the drug encapsulated show a higher cytotoxicity effect compared to the control and also compared to the drug, to the free drug, especially at shorter times. So next, we wanted to explore if magnetic hyperthermia could have a further improvement of this cytotoxicity effect. And this is what we really observe. So when we apply magnetic hyperthermia, there is a further reduction in the IC50 of the drug, being the thermoresponsive sample formulation, the one that showed the highest activity gain. So this is also confirming a different model in a more complex advanced model, in 3D spheroids. So this is the optical image. This is what you can see in the confocal, in a top view of this spheroid. So in this case, we added our formulation followed by 1 hour magnetic hyperthermia. And we repeat this 2 more times. So we did it once every other day during 1 week, and then we evaluate the tumor growth, the spheroid growth in the next 2 weeks. And you can see how our sample formulation is able to revert the positive spheroid growth when only the free drug is administered. We can see also some reversion with the temperature-insensitive drug, but this is, we have to remind that this is a closed system and probably is not completely optimized in terms of legal. No? So we can still see some response of the temperature-insensitive control. And this is what you can see here. So for the sample, for the thermoresponsive sample, if we plot the mean daily growth, you see that this is the best effect in that regard. So we evaluated other different biological assays in order to study the anti-tumor effect of this formulation, so proliferation. Also, we studied ex vivo CAM model in which we studied angiogenesis, for example, also tumor proliferation, migration in vitro as well. So in all the cases, I haven't showed you this data for the sake of time, but in all of these assays, the anti-tumoral activity of the formulation was much better than that of the free drug. So with this, we move to in vivo. So in this case, we administer the animal groups, different animal groups, with the formulation followed by 1 hour magnetic hyperthermia. So we did this once every other day during 1 week, and we evaluate the tumor volume in the next month. So there are different animal groups with different sample and controls. So first of all, what we wanted to see was if magnetic hyperthermia actually could induce an accumulation of the formulations in the tumor region. So what you can see here are 2 MRI images of 2 different animals administered with the thermoresponsive formulation, both of them with the same thermoresponsive formulation, but only one of them subjected to magnetic hyperthermia. So what you can see here in these parametric MRI parametric maps is that there is a clear reduction of the T2 relaxation time. There is a reduction of the T2 relaxation time, and this is what you can see here in this T2 distribution profile. So there is a shift to shorter times when we apply magnetic hyperthermia. And if we extend the statistics to all the individuals in the groups, you can see clearly how there is no difference between the control and the sample, but without the application of magnetic hyperthermia. But when we apply magnetic hyperthermia, you see how there is a significant reduction in the T2 transversal relaxivity. So with this here, I show you the therapy efficacy studies where we confirm actually what we observed before. So we know already that the application, the magnetic stimulation is able to accumulate, to activate this targeting strategy and accumulate the formulations in the tumor. And this is what we confirm here in the therapy efficacy study. So it's difficult to follow because there are many animal groups, many different colors. But if you believe me, you will see that there is no almost difference among groups without the application of magnetic hyperthermia. But when we apply magnetic hyperthermia, you can see that the animal group administered with the thermoresponsive formulation is the one that led to the lowest tumor volumes and to the highest tumor growth inhibition, to the highest tumor growth inhibition rate. So with this, I try to show you a different way of targeting solid tumors, which in our opinion is a versatile strategy that can be applied to other kind of platforms and also to other kind of conditions and diseases. And with this, just to conclude, I want to thank the team, especially this guy, Efres, who did most of the work, who is now in the University of Granada in Spain, also the collaboration in this work of the Professor Fatima Baltasar group, and Monica in the next door university of Minho, and the funding, especially this MAC Targeton from the National Funding Agency. So thank you very much.
Thank you very much for the amazing talk. In the interest of time, we are going to limit our number of questions to one to follow the discussion at lunch. So do you have any urgent question right now?
Hi, Manuel. Very nice talk. Just a question. When you apply the hyperthermia to release the PEG, do you have a look to the stability and the state of the wax particle, how it is? It is, let's say, start to degrade, and if you have a look also to where the biological, the cargo is released, it is released outside the cell or mostly inside the cell?
Yeah, thank you for the question. Yes, we studied this, the effect of magnetic hyperthermia on the morphology of the formulation before and after the application of magnetic hyperthermia. And I can say that the integrity of the system is preserved in somehow. So you can see some bars in the particles. So there is changes in the morphology, but still you can distinguish, let's say, relatively well-formed particles. Because this is one hour magnetic hyperthermia treatment. And regarding the second question, yes, probably you have both. You will have some release of the drug out of the cell, because in the end this is a delivery system which is in equilibrium with the medium, so you will have some release outside. It is not a problem, I have to say, because if you have your formulation accumulated in the tumor region, that's fine. But also we can see by confocal images, with time, we observe that when the drug is encapsulated in the formulation, you have a higher and enhanced accumulation of the drug also intracellularly. So you are able, when you have it encapsulated, you are able to internalize a higher amount of drug compared to the free drug administration, at least in vitro.
Okay, so in the interest of time, I suggest that we pursue this discussion over lunch. So thank you very much.
Thank you.
And our final talk for this session will be from Professor Louis Francis from Swansea University, and is going to talk about the pharmacogenomic platforms for drug repurposing and future nanomedicines.
It should be on, yeah. Rachel said it was on, yeah. It's probably in that one, isn't it? Try that one, the last one. Okay, thanks guys. Thanks for selecting my abstract for a talk. I realize that I'm just before lunch and it's been a really, really cool but quite a long 4 days as well. So I'm going to skip through my slides quite quickly. And what I'm going to tell you about really is what we're doing in terms of identifying new drugs, identifying new targets, or using a better or more informed disease understanding to really drive API and catalogs of drugs that we can use then and match up with our nanoparticles or our drug delivery vectors. So I work in RBGO in Swansea. It's a reproductive biology and gynae-oncology group, and our major focus in terms of oncology is ovarian cancer. So ovarian cancer is a strange disease. It's kind of a rare disease, but it's very, very lethal with a very low 5-year survival rate. It develops invasion tendencies, so it's high metastatic rate, and also refractory disease. So lots and lots of people have resistance and relapse. And the treatment of the secondary disease is not brilliant. It's doxorubicin. But the foundations for nano and kind of effect or increased efficacy of nano in ovarian is that lipodoxorubicin, lipodox, has a huge effect on refractory disease and is much more efficacious than just doxorubicin as a free drug. Now, the premise for that, I think, is increased penetration, increased drug delivery and bioavailability. And I think that the challenge that we've all talked about, and it's a common challenge, is how do we drive more drug and more accumulation in solid tumor cancer environments in deep tissue. Now, we've talked a lot about intracellular delivery, and it's only a personal opinion. I think as a community, we have to drive increased tumor accumulation. And I agree that intracellular delivery would be great, but I still think that there's a lot of work to do to get more drug to the tumor. So antibody-drug conjugates, we have a large program in antibody-drug conjugates, and I think at the moment, even though ADCs are seen and they're really growing and more getting through trials, it's still below 5% of the drug gets to the tumor using an ADC. So we still have work to do in terms of these magic bullets. So we're at the new age of disease understanding, okay? Molecular profiling, digital pathology, all of those processes are coming through. The age of functional genomics is driving that. And we're trying to do that to understand how we can utilize those techniques, those single-cell genomics or transcriptomics, epigenomics, and DNA variation to see if we can drive new targets for disease. How are we doing that? We're doing that using computational analysis, so high-throughput informatics, looking at publicly available data sets. Where my background is in transcription biology, so we're trying to understand how genes are regulated. And we've developed a pipeline for pharmacogenomics where we take the transcriptome, so the genes that are actively transcribed and are used at the RNA level to make the protein function within the cell. And then the epigenetic enzymes that are modifying the chromatin structure. Now, when we set out to do this, it was during COVID when the lab was closed and nobody could get in the lab. And a couple of our informatics team were like, well, we can be real scientists and do some research now that nobody's in the lab and we're not just analyzing data all the time. And they came up with this pipeline where we could look for crossovers in the regulatory patterns around certain gene families, look for the downstream, look straight at the proximal promoter, but also look at the downstream enhancer sites. And by looking at the complexes that form in the enhancers, we started to look at changes that were driving the different subtypes of ovarian cancer, but also the invasive or metastatic processes that underpin those disease or unmet clinical need in terms of metastasis, invasive disease, and resistance.
We isolated causative enhancers, or enhancers that drive differences in the most lethal high-grade serous subtype. And then we started to look at the complexes of epigenetic enzymes that reside at those enhancers, and we cross-referenced those proteins to drugs that have already been evaluated and have gone through regulatory process. So then we ask in our question, can we take a regulatory approved drug that is used with a different clinical presentation and repurpose that for ovarian cancer? So the data sets are not trivial. The data sets are difficult to understand, but the computer does all the work, so it's fairly easy once you've developed the platform. And you can see there, without going into any detail, that you can go from an enhancer landscape, so transcriptional, regulational landscape, all the way to functional and really starting to unpick the functional changes that we would associate with the clinical presentation and start to map and suggest new compounds. So then we worked with, we don't have a medicinal chemistry team, we can't make compounds, we either use SGC or we work with pharmaceutical partners. In this case, we work closely with GSK. We said, well, we have these targets, could you match them to compounds? These compounds that have gone through clinical trial or in stage 2, stage 3 and are showing to be fairly good, can we enhance them? And first of all, show that the mechanisms that we identify through our informatics portals are correct, and they are leading to, they are causative patterns that if you target them and you drug them, then you can kill cancer cells. And we can see here that using it just very simple in vitro and ex vivo, so we take patient samples, build 3D models, and challenge them with these compounds. They do work, but a lot of the compounds have poor pharmacogenetic profiles. Maybe the solubility is a problem. So then we match that then with our nanomedicine team within Swansea. So we started off in nano a long time ago. We tried to drive and think, well, where's the gap? Where could we drive? We didn't want to get involved in a very complex liposome area. So we started thinking about the gap in polymer nanoparticles. So we had a very, very talented PhD student who was in the audience come in, and I told her, go to chemistry and don't come back until you have a nanomedicine platform. So she went to chemistry, and she developed all of the characteristics and the characterization tools needed to underpin a new co-block polymer formulation. And the only thing we said was we would like it to be compatible with a wide spectrum of APIs and drugs. Because we're trying to match this with these pharmacogenomics, we don't know the types of drugs. We can't control that in the lab, so we needed a flexible platform, and we got that. And Katie then subsequently wrote a small grant to do the single-dose toxicity and look at particle accumulation. So we did a basic xenograph model, and we see that ovarian cancer, you have peritoneal metastasis. So we wanted to see if we could drive a polymer co-block formulation that was compatible with interperitoneal delivery, which is what the clinicians tell us that they want. And we can see that when we analyze the data from the small mouse study, that we get accumulation in the peritoneal space. And then as we get drop-off of the fluorescent signal in the peritoneal space, we get increase in the tumor model in the xenograft. So the fundamental basis for the community is, and we've heard a lot about this week, is that advanced in vitro characterization to really understand what you have in your tube in terms of your drug delivery vector is super important. But I would say that think about the properties that you want, characterize and drive those properties, but match them with the clinical need. Okay, it's got to be there. And one of my things for this week is we need to get more clinicians and have that clinical drive, because there's no point in us as a community getting the best vector or the best tool, but then the clinicians don't know how to use it, and we can't translate it. So I'm not going to show any kind of real data now, and I'm coming to the end of my talk, but so we have new drugs, we have new targets, and we know how to go after those with new drugs. We have to partner with big pharma to try and get those drugs and get the best compounds that we can. We then encapsulate those compounds. We look at drug release. We make sure that the vector doesn't change in the presence of the compound. We look at release, and we think that we've got something that's compatible with peritoneal delivery. So the next step really is to go back to in vitro and advanced in vitro and start to think about whether we could use combinations of compounds. Okay? So from our informatics and our pharmacogenomics, targeting chromatin modifiers at enhancer sites with basic kinase proteins that work at the proximal promoter seem to give us the larger or the more efficacious predictions from disease. And then we think, okay, can we get more than one compound in? And what's the temporal kind of nature of those combinations? And do we, can we make sure that we're getting synergy? So the whole premise of the talk really is that precision or personalized medicines, for me, personalized medicine is one drug, one patient. Precision is, can we increase the amount of drug to the tumor and be more precise, and hopefully moving forward as a community drive, even more precision at subcellular level. But then as a community, we have to have standardized data sets that we're going to do. So just on the left-hand side there, you've got our advanced in vitro. So we make the vector, we encapsulate the drug, we check that in 2D and 3D models, we check immunogenicity, we check biocompatibility, and we do small mouse studies to show efficacy. And then at that point, as an academic institution, we then have to look to partner. And we have to take that then and look to translate it. And the real novelty we can bring is the new targets, the new drug combinations, and then we have a platform, nanomedicine, to show nano. Now, a lot of partners we then talk to go, well, we like the polymer, but what about this particle? What about this approach? I think we have to be open to modify our approach and share the best technologies in terms of precision and development. But I think that showing really that the drug combinations and increased efficacy by using nano, the precedent is there. The time is right now for the whole community to drive. And I think it's a really exciting space, and really glad that so many good scientists across, not just the UK, but globally are driving the efforts in this space. So that's our little contribution to nanomedicine. It's our little contribution to trying to combine nanomedicine with genomics and patient-derived data at large-scale genome changes that occur within disease. And happy to take any questions.
Thank you very much for the fantastic talk. So in the interest of time, we're as well going to limit the number of questions and to further discuss this during lunch. So do you have any question?
Hi, Lewis. It was a great talk, and congratulations to Katie on doing all the work behind the talk as well. I guess my question is, at the moment, the delivery system seems to be for predominantly small molecules. And obviously, there's a big push for immunotherapies and now these DNA vaccines for cancer treatment. Is there any plans in the future to try and see what those kind of combinations might look like? I don't necessarily mean in the same particle. I mean, combination therapies with those immune checkpoint inhibitors and these kind of delivery systems.
Yeah, so at the moment, we're looking to see if it's compatible with kind of microRNA, small RNA deliveries, to see if we can do anything there. It seems to be incredibly flexible. It seems to take lots of payloads and be able to release those payloads. It has been designed, and anyone who wants to ask questions about this needs to ask Katie, not me. It's designed at a point where we can internally conjugate a payload as well. But then obviously you have a certain release, so you'll have a burst release once you get to the tumor. But no, I think, yeah, we're working on it. We're looking for funding to open out the types of APIs that we can include. To try and make sure that we keep pace with kind of that immunotherapy and especially in ovarian, it's a very, very cold tumor system. So trying to light that up and turn it to a hot tumor would be really cool.
Okay, so thank you very much. Okay. And I encourage you to continue this very interesting discussion in front of some quiche or salad, or at least what will remain about this. I think we still have an announcement to be made, but thank you very much for joining this session. I found it absolutely interesting, and I hope that you feel the same.
Before you go anywhere, we've got some real-time conference planning announcements to keep you up to date with. So the first thing is good news. The lunch break is on till 1:30, so we're going to give you a bit more time to enjoy lunch, but we're going to make you work for it. We need you to take your posters. If you haven't already done so, we need you to take your posters down by 2 o'clock. If we're going to assume that if they're still there by 2:30, you either don't want them or you're going to dispose of them in some way. So if you can, use a bit of that extra time to try and take the posters down. That'd be a big help for us. And the very last thing that I would say is, obviously there's been fantastic talks across a range of speakers over the entire week. There are some poster and presentation awards later on today. It'd be great if you could stay to support that aspect of the conference. That'd be fantastic. Thanks very much.